the use of high flow nasal cannula versus non-invasive, specifically CPAP versus BiPAP. Dr. Evans, could you give us some insight into your experience with that and some of the data behind those three entities, high flow nasal cannula versus CPAP versus BiPAP with COVID-19?
Sure, thanks for the question, Dr. Davison, and I'm happy to be here and join the group today. It's a tough question and a good one, and I think it's one that's come up again and again throughout the course of this pandemic as to what is the optimal respiratory management for patients. And I think, you know, if we look back to March of 2020, which seems like such a long time ago now, remember there was a lot of conversation going on then about really intubating patients very early, and I think we may have the opportunity to get into early versus later intubation later in this conversation, but you know, at thresholds such as like 6 liters nasal cannula oxygen, and what that did probably was overwhelm our ICUs with intubated patients from that. And I think there's a lot of respiratory support options out there for patients with severe COVID pneumonia or COVID-related ARDS, including high flow nasal cannula, including CPAP, including non-invasive positive pressure ventilation like BiPAP, and including obviously mechanical ventilation from that. Early on, there was no direct evidence in COVID, but there was indirect evidence that we extrapolated from other conditions causing ARDS around the use of high flow nasal cannula for acute hypoxemic respiratory failure. And so I think some of the audience may be familiar with it, but there was a New England Journal publication called the Flora-Lee trial, which randomized patients to high flow nasal cannula versus conventional oxygen therapy and looked at both mortality as well as progression to mechanical ventilation. And that trial showed a substantial decrease in mortality with the use of high flow nasal cannulas compared to conventional oxygen therapy. Following that, there was a meta-analysis done, a couple meta-analysis done, but at least one that I would recommend the group look at is by Bram Rockwork from McMaster in Canada, that looked and saw that in the meta-analysis of clinical trials that high flow nasal cannula compared to conventional oxygen therapy did not reduce mortality and did not affect ICU length of stay, but did reduce the progression to intubation and invasive mechanical ventilation. So early on, people, I think, sort of took that indirect data and said, well, should COVID, behave that differently from other causes of ARDS and sort of use high flow nasal cannula? Probably in preference to conventional oxygen therapy when patients have remained hypoxemic despite conventional oxygen therapy. There's been a lot of anecdotal use of both CPAP and non-invasive positive pressure ventilation. I think initially, early on, again, probably a year and a half ago, there was some hesitancy potentially around the use of non-invasive ventilation, largely based on infection control and prevention considerations as to whether non-invasive positive pressure ventilation sort of increase the level of aerosolization within the patient room. Subsequently, though, there's been a few trials of non-invasive ventilation from that, and the most recent one that I want to bring people's attention to is it's only available in preprint so far, but the REMAP-CAP trial, which is a large multi-center adaptive randomized controlled trial of multiple therapies for in this case, COVID-19 pneumonia. Remember that those studies, some of the studies that Dr. Everhart described around tocilizumab were done in the REMAP-CAP study, but they also randomized patients to CPAP versus high flow nasal cannula. And interestingly enough, this study, again, available only in preprint so far, not yet peer reviewed and published, showed a reduction in mortality with CPAP compared to high flow nasal cannula, reduction in the progression to invasive mechanical ventilation. So we're left kind of with some interesting trials, indirect data suggesting that high flow nasal cannula reduces the risk of mechanical ventilation in patients with acute hypoxemic respiratory failure, and one large multi-center open label study looking at CPAP that did not show benefit of high flow nasal cannula. So I think we'll have to take that data in totality and decide if we think the REMAP-CAP data really says that high flow nasal cannula doesn't reduce the risk of mechanical ventilation in these patients. But certainly I think it describes an approach to safe and hopefully efficacious use of CPAP in these patients as well. So let me stop there. I want to take the opportunity that the study I mentioned just a moment ago, I misspoke, and it's actually the recovery respiratory support trial, not the REMAP CAP study. So a UK-based trial for that, but same findings, same multi-center adaptive open label study.